Good evening, everyone. My name is Nevis Bernardi, and I'm the Secretary of the Board of Directors at Turning Point. Thank you for joining us this evening. At Turning Point, we are deeply committed to providing support and resources to meet the mental health needs of our community. Founded in 1969, Turning Point is a nonprofit outpatient mental health center dedicated to serving children and adults. With locations in Skokie and Evanston, we provide solid support when and where you need it most by delivering approximately 26,000 service hours annually to over 1,100 individuals across the Chicago metropolitan area. Welcome to our community education event, Typical Growing Pains or Mental Health Red Flags. Our facilitator tonight is Amber Greviskes, a fourth-year clinical psych student at the Chicago School pursuing her doctorate in psychology. With a background in news editorial journalism from the University of Illinois at Urbana-Champaign, Amber has dedicated years to supporting survivors of sexual assault and domestic violence. Her research focuses on trauma, including crime victims' experiences and vicarious trauma in first responders, as well as policies addressing the decriminalization of mental illness. At the Naomi Ruth Cohen Institute, she furthers this passion by supporting mental health first aid and developing mental health education programs. Thank you to Advocate Health in partnering with us to bring this important educational event. We invite you to stay connected with Turning Point, whether by visiting us in person or exploring our services at tpoint.org. And now it's my pleasure to give Amber the floor. Welcome, Amber.
Thank you. And thank you so much, everyone, for joining us today. I know school's just getting started and it's just a very busy time for all of our caregivers. So I appreciate you being here. Today, the purpose of our conversation is really to discuss children and their mental health concerns or their mental health challenges. Our learning objectives are going to be to recognize the signs and symptoms of potential mental health concerns, learning how to ask your teenager questions about their mental health, learning strategies to support teens in managing their emotional well-being, understanding when and how to seek professional help for teen mental health issues, and then learning how to prepare your teen for their first therapy appointment. I've spent the last few years at various organizations that work with children and adolescents, and that first appointment can be really kind of scary for both our caregivers who don't know what to expect and their teens. So our goal today is to make sure that you feel better prepared to know when to ask for help and how. Now, one of our questions that we often get is, why does everything seem to kick up during the teenage years? We have a lot of different things that are going on developmentally from a biological perspective, a cognitive perspective, and kind of a social perspective. So first, physically, your brain is really developing rapidly. You're getting more of your problem-solving skills, you're doing a little bit more reasoning, but it's still not there completely. You also are experiencing some puberty type changes. So there's hormones, there's different things coming that you're like, why am I all of a sudden feeling so very, very anxious? We also have different things that are going on socially. So there's some emotional development, some things with identity formation. This is a lot of times why those peer relationships become so important. We're also learning how to navigate independence and preparing for what's next. So a lot of teenagers, even if they're at a point where mom and dad and grandma, grandpa, aunts, uncles, other caregivers still see them as kids, they're very much excited about learning to drive cars and going away to college. Now, first of all, I'd like to normalize some of our mental health concerns that we're seeing. So if you know a child who's struggling, it's not uncommon. Among U.S. high school students in 2023, 40% reported persistent feelings of hopelessness or sadness. 20% reported seriously considering attempting suicide, and 16% reported making a plan to die by suicide. Additionally, 22% reported drinking alcohol in the past 30 days, and 17% reported using marijuana in the past 30 days. Additionally, we know that 1 in 5 youth between the ages of 9 years old to 17 years old has a mental health disorder, but only 1/3 of these individuals are able to seek treatment. 50% of all lifetime mental illnesses begin around age 2014, and then youth mental health hospitalizations increased dramatically between 2016 and 2022. So if all of a sudden you're thinking, wow, I never heard about this before, it wasn't in the news, I didn't know, it's also because we're seeing a dramatic increase. Additionally, 55% of the US public believes there's a mental health problem. Now, if you're somebody who cares about a child, whether you're a coach, caregiver, someone else, here's some signs and symptoms there might be a mental health challenge. And I say challenge because if you're a parent, if you're a concerned person, you're not necessarily able to diagnose. You just know that something's not quite right. So signs are things that we see that may indicate a mental health challenge. Things like unexplained weight loss or weight gain. Maybe we see some behavior changes, the slamming doors, sleeping too much, too little, not wanting to invite people over. And then there are symptoms, so feelings that are indicators. If your child says that they're sad or that they're unhappy, or if you notice them being very anxious to go to school when they used to love it, those could also be feeling related indicators of a mental health challenge. Again, some of these things are a little bit harder to see. So if you're thinking, how do I know if my child's sad? That's kind of a thought, that's a feeling, that's in their head. Again, we want to pay attention to appearance, behaviors, feelings, and words. So what are they saying? The other thing we want to pay attention to is the frequency, intensity, and duration of these things. So for example, I was really nervous today getting ready for this presentation. I wanted to do a good job. But that's a one-time thing, and I'll be okay tomorrow, or even 5 minutes after this is over. That's normal. If I was feeling anxious every single day, that would be something that maybe somebody would want to talk about. Intensity. Here we're really talking about whether or not a concern is, or whether or not a reaction is too much. And again, it's too much for your child. So if we're seeing things that are out of proportion, being anxious for a school performance, appropriate, being anxious every day is not. And again, being a little bit anxious where you have butterflies in your stomach, that's okay. But feeling so anxious that we can't get out of bed, that's a little different. And then again, duration. So if we're thinking about how long something's been going on, a week when we're getting ready for SATs, ACTs, those kind of tests and standardized things, if we're getting ready for a sports performance, or maybe we're going to ask somebody to dance, that's one thing. If it's going on for weeks and months, then we're talking about something different. All right, so talking to teens. One of the best things we can do is choose an appropriate time to talk to teens. We want to make sure that it's a time over the weekend when we have some downtime to reflect and where we can have a thoughtful conversation. Asking somebody on the way to school is probably not the best idea. We want to ease into the conversation, so we're talking about what we've observed. I noticed that you haven't invited someone over to play lately. I noticed that you haven't mentioned that person. Is something going on? And then listen, really listen to pay attention to what they're trying to say. Saying something dismissive like, it's okay, you're smart, it'll be fine. Or these things, these breakups happen, you'll be over that person by tomorrow, isn't validating. So what we could say instead is something that helps normalize their feelings. Yeah, it's really hard to start at a new school and be a freshman when you may or may not know somebody, or you're having a new teacher. I wonder what that's like for you. Ask if they've thought about what could help. So maybe they're overcommitted to activities and they don't want to let somebody down. For a lot of the children and adolescents that I've worked with, I can be the bad guy. I'll say, oh, just tell them you have a meeting or an appointment, or that mom, dad won't let you go. That's okay. And then, of course, be willing to get help. So occasionally children, especially teens, don't want to talk to their caregiver. In those instances, you may offer to let them speak to a mental health professional. Now, that can be a social worker or a counselor at school, or they may say, I don't really want to go into the office at school. Is there somebody else? In that case, that's when you'd look to an organization outside of the school, like Turning Point, to get some assistance. Another thing that we're going to talk today is about the differences between various kind of normal reactions to situations, and then also what leads us into more of a mental health disorder. So again, if we're thinking about stress versus anxiety, stress is the natural reaction that your body has when challenges or changes occur. It can keep you alert. For example, if you're thinking about driving in traffic and ready to avoid danger. Everyone experiences stress from time to time, especially in middle school and high school. However, anxiety becomes a concern when those anxious feelings stick around for weeks, months, and interrupt your child's ability to engage in home, school, or work environments if they have a part-time job. Again, when we think about our symptoms, they're going to be things like being easily fatigued or very wound up. Sometimes we might think about that as being like a little bit irritable. As a caregiver, you might see changes in eating, difficulty concentrating, feeling restless or on edge, headaches, stomach aches, other pain, muscle tension, nervousness, problem sleeping, and occasionally substance use. We say that substance use is a symptom for both anxiety and depression because it can be kind of something that helps teens feel like they're coping. They may feel more outgoing and less anxious if they use a substance. They may feel less sad, but obviously we know that's not a solution. So depression, occasional sadness is a normal part of growing up. However, I think one of the things that happens is that adults can minimize children and adolescents' experience of both depression and anxiety. So children as young as 2 years old can experience depression, and we know now that more than 1 in 7 teens experience depression each year. Additionally, 10% of high school boys and 22% of high school girls reported suicidal ideation in the past year. And if you look at some of the little bubbles that we have on the side, we're going to see again signs and symptoms of depression in childhood. They're very similar to the ones about anxiety. Here, however, you might see a little bit more of the social isolation and withdrawal, a loss of interest in fun activities, and maybe having a little bit more low energy. Again, here we have some depression symptoms. I think the one we'd like to draw attention to here is something that in the past has been called attention seeking. So if you think about maybe children and adolescents who engage in big externalizing behaviors, they're stomping their feet, they're slamming doors, they're doing things that most people would say are just kind of like, why? Why are you doing this? We really want to think about that as, especially if it's a change in behavior, really them asking for support, them asking for help, but maybe not having the words. Again, any change in your child's behavior is something that you want to pay attention to. Now, a couple of the things that can be difficult for caregivers to think about are self-harm and suicide, which we're going to talk about next. So if you need to take a break to take care of yourself, feel free. If you want to turn off your cameras, that's fine too. We want to make sure that you're comfortable throughout the presentation, and this will be recorded. So if you need to take a break and come back later, it'll be on the website so you can do that. So self-harm happens when individuals hurt themselves on purpose without intending to kill themselves. Mental health professionals may also refer to this as non-suicidal self-injury, or NSSI. Usually people think of self-harm as cutting, but it can also include hitting, scratching, burning, and headbanging. You may notice children and adolescents who have scars or who are wearing clothing to hide scars. Self-harm does not mean that someone is having thoughts of suicide or wants to die. They're often in overwhelming emotional pain. However, repeated self-harm, especially when injuries are severe and need hospitalization, can predict that somebody may eventually attempt suicide, and that's especially true in young women. Again, this is potentially a little bit more of a difficult kind of section, but suicide attempts, ideation, and self-injury have become the most common mental health conditions in children's hospitals' emergency departments. Between 2016 and 2022, children's hospitals saw a 166% increase in emergency department visits for suicide attempts and self-injury among children from ages 5 to 18 years old. Approximately 2 million adolescents attempt suicide each year. Among U.S. pediatric deaths, more than 25% are by suicide. Suicide is also the second leading cause of death for children and young adults ages 10 to 14 years old. Not only are the numbers increasing, but we're also seeing worse acuity, according to one of our doctors over at Children's Hospital of Orange County. When we think about suicide in youth, there's kind of really three ways to break it up. So it's elementary school aged youth, then we have pre-adolescence and early adolescence and adolescence. We think about these differently because of where children are in the developmental spectrum, as well as kind of their access to different means to die by suicide. So between the ages of 5 and 12, we usually see that the children begin to understand the permanence of death and may experience intense emotions related to bullying, family conflict, or trauma. While suicide is relatively rare in this group, it does occur. What's more likely to happen in this group of kids, especially because death is a little bit foggy, especially at the age of like 5, 6, 7, is that if a grandparent, parent, even a pet, aunt, uncle, cousin dies, they may say something like, I wish I could be with so-and-so. I wish I could see so-and-so again. And a lot of times that may make people nervous, but it's really important that we're able to get curious and say, like, what do you mean by that? And it might just be, I miss them. Or they may say, I wish I was dead. So, and if you ask, why do you say that? It's so I can see this person again. So we always want to make sure that in addition to being very prepared and being open to having these conversations, that we don't get so anxious that we cut people off. When we talk about pre-adolescence and early adolescence, we see an increase in suicide risk. A lot of this has to do with physical, emotional, and social changes. There might be identity struggles, social pressures, and then increasing likelihood of anxiety and depression. This is really where kids, again, start to feel more like there might be pressure to be popular, to have things that other children have, to kind of live up to all the ideals on social media or in different types of movies if they have exposure to those types of things. In adolescence, we see that suicide risk peaks in late adolescence due to intense emotions, identity struggles, academic stress, and relationship challenges. Factors like impulsive behavior, social media influence, exposure to suicidal peers, and substance use elevate that risk. Adolescents are also more likely to have access to lethal means, and their suicidal actions are often more deliberate. So when you think about adolescents, you really have to be aware that their worlds can be a lot bigger than we think, depending on what they have access to in the social media space. And then also when we think about lethal means, we also have to be aware that there are more than just, weapons and those kind of things that can be lethal. There are also medications that are found over the counter that children can get access to. Right. When we talk about our risk factors, it's psychological development. So adolescents may experience more stressors related to identity formation. Um, in your 20s, 30s, well, I should say in your 30s and 40s, you kind of realize like not everybody's going to like you, not everybody's going to be your friend. It's going to be okay. When you're young and your world's still fairly small, it's a little bit harder, especially if you go to a small school, or you're with the same group of people that you've been with your entire life and you can get like labeled one way or the other. Social development, we see a lot of bullying, isolation. There can be concerns with family dynamics, if other people are fighting or having a hard time. And then again, we have our peer relationships. With biological factors, there are genetic predispositions, including chronic diseases and disabilities, as well as underlying mental health conditions that can contribute to suicidal thoughts. Environmental stressors kind of include any of our different exposures to trauma. So we're talking about abuse, neglect, um, any kind of like big scary thing that has happened. There's also family conflict, parental substance abuse, and then socioeconomic disadvantages. We can also see risk factors increasing when we have a lack of access to supportive resources. So that can be mental health services as well as supportive adults and crisis intervention resources. So when we think about supportive adults, there will be times potentially in our children's lives where they just don't want to talk to us. Um, I think, 20 years ago, even more than that, when I was on my high school cross country team, there were times where none of us talked to our parents, but our coach always knew what was happening. He drove the van, he got us places, he heard all the gossip, he knew what was happening. And I think people would have trusted him if they had a problem and could go and talk to him. And then alternatively, our parents also trusted him that he would make them aware of things that were going on that we needed additional support with. Um, Obviously, because he worked in the school environment, he was a mandated reporter, so he would have had to alert all proper authorities if somebody had disclosed abuse, suicidal ideation or homicidal ideation. But I think aunts, uncles, cousins, um, mentors, any older adults or older people who potentially can be supportive are good people to have in your child's life. And if you haven't had a conversation with them yet about, hey, so and so's going through something, and I don't need to know everything, but I do need to know if there's ever something big where I need to get involved. That might be a conversation that you might want to have with them. Again, we also think about risk factors and we think about access to means. So we've got lethal means such as firearms or medications that can elevate the risk of impulsive suicide attempts. When we think about risk factors, we also have to talk about protective factors. So we have a caregiver's unconditional love, being able to spend time with a best friend, volunteering or helping others, being active in social groups, having a mentor outside the family, living in a clean, safe home with enough food, having the opportunities to learn, having a hobby, being active or playing sports, having routines and fair rules at home, being able to talk with family about feelings, feeling that family members are able to stand by children during difficult times, feeling safe and protected by an adult in the home, having at least two non-parent adults who take genuine interest in somebody, feeling supported by friends, feeling a sense of belonging in school, and participating in community traditions. Um, I think one of the things that's important that might be something that can be a little bit harder, especially after the pandemic, is really thinking about what our other touch points are in the community. So for most of 2020, definitely part of 2021, a lot of us were very isolated and alone. So as we branch out and reestablish those connections and bonds, we want to make sure that we're surrounding our children with people who are supportive, kind, and have the same values kind of that we do across the board. One of the things that people occasionally get very concerned about is suicide contagion in clusters. Suicide contagion refers to the phenomenon where exposure to suicide within a community or through media exposure can lead to an increase in suicidal behavior among others. Media can make this seem bigger than it is. Highly publicized suicides can lead to an increase in suicide attempts among vulnerable populations. So there are guidelines that are now established for media members to follow when reporting on death by suicide, so that people can actually be a little bit more protected, and so they can be more aware of what they're doing and how it's impacting other people. We also think about social circles. So suicide can spread through close-knit communities. When one person dies by suicide, others may see it as a solution to their own struggles. So again, we want to be very proactive. We want to take care of all the kids in our communities so that, you know, if your child's best friend is struggling, maybe you just say like, oh, hey, if you ever need anything, feel free to let me know. So that we kind of protect everybody. And again, once something happens in the community, we want to make sure that we are very aware of it and that we talk to our children about it in a developmentally appropriate way. There are two types of suicide clusters. One are point clusters that represent a greater than expected number of suicide or suicide attempts that occur within a time period in a specific location. And then there are mass clusters. So these are ones that are spread out more geographically. So this might be kind of the difference between something that happens in like a school or a small community versus like when Anthony Bourdain died and then Kate Spade died that summer, and then, you know, multiple people died by suicide in fairly quick succession, and it was very widely publicized over CNN and other media outlets. With youth, we want to make sure that we're paying attention to these warning signs, and you can take a picture of this slide if you want. One of the things that all mental health professionals are trained to look for is what is an immediate risk versus a serious risk. So a serious risk is behaving recklessly. If we think about people who drive their cars really, really fast on the interstate at 2 o'clock in the morning, and you're like, you're going like 95 plus, like that might be a very concerning behavior. Extreme mood swings, increased substance use, isolating oneself from friends and family, again, sleeping too much or too little, and then talking about being a burden, feeling trapped, feeling as if you're in unbearable pain, or talking about taking revenge on others. Immediate risks would include things like looking for a way to die, obtaining means to die, or talking about wanting to die or kill oneself. Here we might see people talking about feeling hopeless or having no reason to live. Regardless of where your child falls, if you don't know what to do and you're feeling overwhelmed, you can always call 988 and talk to a mental health professional or a counselor there who can give you some information and some resources. There are also in Illinois various different types of hotlines, so you might call them for support, and we'll have resource slides at the end. All right, so talking to teens. Again, a lot of these things are going to be similar to when we talk to any teens about any kind of mental health challenge. However, with suicide and self-harm, we want to make sure that we're giving children and adolescents time to answer. So we are going to ask direct questions. Have you ever thought about hurting yourself? For some people who are not experiencing suicidal ideation, they might say like, no, what are you talking about? Or you might ask them if they have hurt themselves, and you'll have a kid say, oh yeah, I fell out of a tree and broke my arm. In that case, we're fine. Nothing is happening. Whereas you might have a child who like thinks about it and is like, yeah, actually I have. You might want to say something like, have you ever thought about going to sleep and not waking up? If they answer yes to that one, then you might want to follow up by saying, have you ever thought about killing yourself? We ask these kind of in a progression because have you ever thought about going to sleep and not waking up? Could be something where you're like, yeah, I would really like to sleep through all of this weekend because it's homecoming and I don't have a date and I really don't want to go back to school on Monday. That's very different than this last one. When we are asking clarifying questions or when something they say doesn't make sense, which can happen when you're on a different page than they are, can be saying something like, help me understand what's happening or tell me about what's going on. With these kinds of statements, you're giving your child or adolescent all sorts of room to explore what's happening in their world. So it might, and you might actually be able to come up with some solutions. So if we're experiencing problems with bullying, peers, those kind of things, it might be something as easy as saying like, okay, well, what if we talk to school about moving you into a different class? What if we, the problem seems to be the bus. Okay, let's see if we can figure out a way to carpool with somebody. There may be ways to problem solve that if you leave questions very open-ended after you've established safety, you can help figure those out. We always want to assume that people are telling the truth about feeling suicidal. We want to assume they're not joking. We don't want to say like, oh, but you would never do it, right? Because then they're going to say like, oh, no, no, no. And we want to make sure that we're not judging. So again, by staying calm, we're able to get more information. We're able to make sure that we don't shut down the conversation. And we're able to make sure that that person who may be disclosing for the first time is able to feel seen and heard and validated. And again, with a lot of these conversations, especially if somebody says, no, I don't want to hurt myself now, but I'm having a really hard time at school, you can say, okay, would it be okay with you if we checked in on this tomorrow, in a couple days, even next week? When we're talking to teens, we want to pay attention to early intervention. So we want to prevent escalation. Addressing suicidal ideation early can prevent thoughts from escalating into attempts. Underlying issues can also be addressed. Access to supports can also be provided. So if, for example, you notice something happening and it seems like it's depression or anxiety, by intervening then, you can help set them up for success later. So one, you've kind of established an open line of communication, but also you've maybe made some people aware in different environments that they're having a hard time. Maybe the bus driver doesn't know they're being bullied, or a teacher at school isn't aware that they're having issues kind of across the board with classes since moving to a new school. We can also help children and adolescents build coping skills. Coping skills can kind of be one of those things that mental health providers use, but it basically means like what helps them when things are going wrong. And the first step to building any coping skills is going to be to notice what makes them upset, what makes them anxious, what makes them sad. A lot of times we don't know until we stop and think about it. And somebody says, well, when did this start? When did you first notice it? How often does it happen? As we become aware of when things are happening, we can help them figure out what might work. Could breathing work? Could going for a walk work? Could going to bed on time work? We can also build in problem-solving strategies. One of my favorite ones is figuring out who the people are in our life who we can talk to. So sometimes we have friends that we just call when we need a distraction. I just want to talk to you. I'm having a bad day. I need to vent for 5 minutes. And that's going to be it. I'm going to feel better. Our next person, our next line of defense could be somebody who you know you can reach out to when you're like, this is bad and I need to like actually talk to somebody. I don't need a distraction. I need somebody I can problem solve with. I need somebody who's going to listen to me. And then the third line of defense can always be like, okay, we've gone through those things. Now who do I talk to? And that could be again like 988 or crisis number. It could also be something like going to an emergency room. We'll work on in the coping skills section, also building kind of regulation techniques to help manage stressors. One of the benefits of early intervention is preventing long-term effects. So suicidal thoughts and behaviors can have lasting effects on young people. And early intervention can help mitigate these effects. Inevitably, whenever children or adolescents come to therapy, we're going to involve caregivers in the assessment and treatment process so that everyone can support the young person's needs. It's also because sometimes when we're in a very bad place, and I say this even as adults too, when you're having a really difficult time, it can be hard to be like, what was it like before? What did I used to enjoy doing? What used to make me feel better? And having caregivers around who can point those things out can be really, really helpful. We're also going to want to pay attention to promoting open communication, reducing stigma, and making young people feel comfortable discussing their struggles and getting assistance. All right, so generally we think about assessing suicide risk as a spectrum. So there's kind of the green side where we're seeing like no suicidal ideation. There's a normal focus on end of life issues. So we might see something like, a kid realizes they're becoming an adult, maybe somebody else they know dies. We might have different kind of conversations about what's happening as people age. Then there might be thoughts of death that are passive suicidal ideation, where you have not considered a method to self-harm. Then there's thoughts of suicide. So you've considered it, thought about what could do, but you would never do it. And then a specific suicide plan or intent. As we move through the stages, it kind of comes through like very low risk to like, we don't need to do it, but maybe we'll keep an eye on it, to like, we cannot leave this individual alone. When we're working with children and adolescents, you'll usually see a mental health professional do an assessment for all of these things and talk to the caregiver about all of these things before anybody makes a determination about what the next step would be. One of the last things we're going to talk about is how to create a safety plan. The way these are usually done is with a child's input so that we can keep the child safe. Again, we're going to want to talk about triggers and warning signs. So again, things that the child might notice in themselves. I feel my face get red. I feel my stomach upset, and also things that others might notice from the outside. I feel I clench my fist. I pace a lot. Coping strategies, so ones that they can do, maybe it's noticing different things around the room, like a 5, 4, 3, 2, 1. 5 things I can see, 4 things I can hear, 3 things I can touch, 2 things I can smell, 1 thing I can taste. Then there are coping strategies that others can help with. So that might be letting somebody go for a walk and going with them. Another thing might be leading somebody through some breathing activities. And then again, we talk about our people who can help. So people who can distract us, people who can help us, and people to reach out to in case of emergency. The key parts of safety plans include identifying warning signs that a crisis might be emerging, developing internal coping strategies that can be used alone, identifying social settings and people that can offer distractions, lists of family members and friends who can support during a crisis. Also, I like to include, if we're going to list people's names, that we're also going to put their phone numbers so that way we can make sure that we can get a hold of them, even if we're sitting in a principal's office or we're kind of out in the world somewhere and we're asking somebody else to make the phone call for us. Occasionally, depending on what the situation is, we might have like a code word or like a little emoji that you send so that you know it's not just like a, hey, how's it going? And it's like a, nope, you need to drop everything and pick up your phone. We're having a crisis. A list of emergency contacts and professionals to contact during a crisis. And then obviously, whenever we make a safety plan, we talk about reduced access to means. So any kind of means that are in the home that don't need to be there, we would ask you to give to a relative, give to somebody else for safekeeping. Anything that you need to keep in the home. It can even be like putting medications in like an office drawer in your glove box, somewhere where your kids can't get to them. Those types of things. This is an example of what a safety plan can look like. Again, it's really just to kind of familiarize yourself with them so that they don't become scary. And again, whenever we do these, we want to make sure that the child or adolescent is able to assist us with this because they might have ideas about people who can help that maybe we didn't think of. And also, especially for ways to make the environment safer, some kids will say things even like, you know what, as soon as we bring the lights down, I feel calmer, I feel better. Opening a window, getting out in fresh air, whereas other children want the exact opposite. As far as resources go, the biggest ones are going to be obviously 988, 911. We have a crisis text line number listed here, which again, you can take a screenshot of. And then any emergency room is someplace you're going to want to go. If you have the ability to take a child to an inpatient facility. So in our area, it would be places like River Edge, Streamwood, Hartgrove, Garfield Park, those types of facilities. You're going to have a slightly different experience than an emergency room. So emergency room, the first people who are going to get treated are people who aren't breathing, who are bleeding, all of those types of things. Whereas if you go to an inpatient mental health facility, anybody who walks through the door is going to be treated as a priority. So they have people there who are available 24/7 to do assessments and intakes. You can always call ahead. But if you feel safe taking your child to one of those facilities, it might be a better option depending on what the situation is. Inevitably, if it's a true emergency, you want to get to the fastest place as fast as possible. We also have the Trevor Project listed and then SAS. So SAS is an organization in Illinois that can come out to your house. A social worker comes to your house or school, and they can do an assessment immediately if needed. We also have Strong Resilient Youth, which is an organization that has various mental health resources. One of the things that you'll want to know about meeting with a mental health professional is that you're going to want to find an appropriate provider. So we want to work with somebody who's the same age as your child. Children who are 5 years old talk about death very differently than college students. And the professionals are going to interact with them differently. You want to make sure that you set up a meeting with your provider. So many people will want to schedule a one-on-one with the caregiver first. It's going to be to review clinic policies, paperwork, and to collect some background information. When do they notice things changing? What do the symptoms look like? You want to be as forthcoming as possible to provide information about developmental history and any kind of family mental health history, just because there are some things that are genetic or have genetic components to them. And we also want to prepare our children to go to therapy. So you can ask the person that you meet with or the person at the front desk who you're scheduling with what the appointment is going to be like and what it's for. A lot of times, especially with younger individuals, caregivers will come in with them for a little bit and make sure they're comfortable, and then they might leave the room so that it's just the provider and the child, and then the caregiver would stay in the waiting room. Many children and adolescents who come into therapy can be involved in treatment for several months. We want to make sure that we choose a therapist who can support you for that amount of time. So obviously we know that insurance changes and those kind of things happen. But if you find somebody you click with, you want to make sure that they're like a good person for you and a good person for a long time. So, just because the first person you can see is in downtown Chicago and it seems like a really great idea, if you have to go every week for 6 months, and it's an hour plus in traffic because you're commuting during rush hour, it may not be a great idea. So you really want to find somebody that meets all of your family's needs. You want to allow for the process to unfold. So for some of the time, the clinician will need to build a relationship with your child. So they may need to keep like the exact details of the conversation private, but they are required by law to alert you and potentially others if there's suspected abuse or neglect, as well as if your child is a danger to themselves or others. A lot of the times, different people do it different ways, but they might give you like a little summary of what we talked about. They might, ask you to keep an eye on certain things, that type of thing. Or they may sit there and ask your child to tell you, like, hey, what was the really important thing you felt like you needed to tell your caregiver, but didn't want to tell them without somebody else there? Most of the time, you won't be required to sit in every session unless your child's very young. However, you're usually required to remain on site. And then this is just something that most caregivers should be aware of, but according to the State Bar Association, as of January 1st, 2018, children ages 12 plus can receive confidential counseling on an outpatient basis. They can be seen for 8 90-minute sessions without parental consent. And also children ages 12 plus must consent to the release of their mental health records to anyone. So again, this is something that all providers who work with children will be aware of. But we want to make sure that parents and caregivers are too. And then these are our references. So does anybody have any questions?
Amber, that was really great.
Oh, thank you.
So many great points and very easy to follow and easy to remember.
Oh, good.
Yeah.
Good, good, good.
That was really great information. There was one thing that's like,
Sure.
maybe a silly question, but you had on a slide, you said a protective factor is if a teen has two non-parental adults who have a genuine relationship with them. And I've heard and been told and, said to other people, like, kids just need one adult to care about them to make a difference. I'm just curious if there's like a statistic about the two. Because
I found I do have one of these articles says too.
two's better than one. I get that.
Yeah, but you know what? I really think it's just about having like a non-parent who's there for you, because sometimes your parents can be the problem. Whether it's just the way they're interacting with you, how they're engaging with you. Maybe they're still treating you like you're 10 and you're like, no, I'm 16, I need privacy. So I really think honestly, anytime you can get any non-parental caregiver involved, and it could be aunt, uncle, like absolutely anybody. You're doing really, really well. Yeah.
I agree. Will you be sharing the slide deck? Is that
I know we're sharing the
the
videos,
recording? Okay,
the
cool.
Yeah.
recording. Yeah, I can
Right.
ask about the slide deck.
Great.
Yeah.
Well, thank you so much.
Of course.
And Allie, we can forward you Amber's contact info
Yeah,
for any other
yeah.
questions or
Any
a resource.
questions or yeah, if you need any other resources or any other presentations, yeah, just let us know.
Thank you so much, Amber. It was really interesting.
Of course. Thank you
Yes,
for
thank
joining
you.
us.
It's very helpful.
Oh,
Yeah.
great.
And I'm so glad that we have this recorded to share,
Mhm.
to keep sharing with people. It's such important information.
Yeah.
Yeah. Yeah. So we'll end tonight. We'd like to thank Amber and the Naomi Ruth Cohen Institute for always being there for us, being our great partners and educating everybody about really important topics. And also our partner in this event is Advocate Health as well. So thank you, everyone. And
Thank you.
if you need any other information, shoot me an email and we can connect you with Amber and Naomi Ruth Cohen.
Great.
Yeah,
Thank you.
thanks, everyone. Have a good night.
Take
Good
care.
night.
Thank you.